So welcome everybody to this BO Watch that we're going to do special here at the World Lung Conference in Singapore. I'm Adriano Silva, medical oncologist in Brazil, and this is Dr. Narjust Florez. She's a medical oncologist and leader of the thoracic oncology at Dana-Farber Cancer Institute in Boston. She's a big part of the Flaura 2 study, the study that we're going to discuss now. The new data that has been presented by Pasi Jain. Thank you, Dr. Florez, for being available to us, and welcome.
It is my pleasure, and I'm always happy to discuss whenever the treatment of lung cancer is changing.
Yeah, it was a very interesting trial to be presented. The Flaura 2 trial just followed the Flaura trial, which was the first line osimertinib against chemotherapy. And now the Flaura 2 explored the combination of osimertinib with chemotherapy against just osimertinib, and we saw interesting data with the PFS increase with a hazard ratio of 0.62. What do you think of this initial data that was presented today?
I think before we talk about the data, let's talk about why are we doing this study, and this comes from the OPAL study in Japan. So this is not something that we came out of the blue. The OPAL study was the pilot to conduct this international study in which patients were added chemotherapy, particularly patients at higher risk. So, and the Flaura 2 study is a randomized global study in which patients were randomized to 4 cycles of carbo, cisplatin plus pemetrexed, with osimertinib or osimertinib alone, which is the standard care in the United States and Brazil and other countries, but not globally.
What do you think about the keeping on the design of the trial? My question is on the maintenance part with the pemetrexed. Do you think we should keep the pemetrexed until progression or toxicity? Because I saw the median time to pemetrexed exposure was about 8 months. Or do you think we should just skip the pemetrexed and just keep the osimertinib? Do you think there's any role for that 8 months of pemetrexed?
So at the data cutoff, only 25% of the patients remain in the pemetrexed maintenance. So your point is very well taken. 75% of patients were off pemetrexed. And I think the challenge with pemetrexed is, first, the creatinine clearance can be a challenge, and second, the bone marrow suppression. So osimertinib has bone marrow suppression. So I think it would be good to classify patients and determine which patients we should remain in pemetrexed and which patients only benefit for induction. And this is something to learn from other cancers. Induction therapies are not new, but they're new to us. So the chemotherapy, I think in Flaura 2, works by producing that initial tumor burden shrinkage, which we know has improved survival in many other diseases and in lung cancer too, and then continue with the osimertinib. So I think the role of pemetrexed is borderline. I will keep it in patients who are at high risk and in patients that we tolerate it. Younger women, for example, these patients will have a longer overall survival, so it would be good to keep them as long as possible. But we don't know yet. The data is so new as 30 minutes ago. Yep. Which are the patients that remain in pemetrexed and which are the patients that should remain in pemetrexed. But I think most patients probably shouldn't, and they should just continue on their osimertinib.
Yeah, you talk about selecting patients. I think this is key. The data shows just a small increase in overall response rate, and I mean we have a huge overall response rate with osimertinib by itself. But my question is, do you think that we should look more into CTCs or ctDNA to assess minimal residual disease to better select this patient who's going to continue on chemo, or even who's going to get chemotherapy in the first place?
So that is very valid. 2 points about that. First, Dr. Janet Lab studied this and published it. So the patients that continue to have circulating tumor DNA after 4 cycles of osimertinib have a worse prognosis compared to that don't. So I think circulating tumor DNA will help classify these patients. Flaura 2 data obtained circulating tumor DNA. So that I think will be presented as the data continues to mature. There's also another study that's coming from Memorial Sloan Kettering that is putting patients in osimertinib, and after 4 months, the patients that still have positive circulating tumor DNA go into chemo. The ones that have negative circulating tumor DNA, just continue on osimertinib. So I think incorporating the biomarkers, incorporating testing along the way will help us, because the disease changes over time.
Exactly.
The disease that the patient is diagnosed with is not the same disease that the patient dies with. And doing these assessments, I think, as the patients continue in treatment, will allow us to understand more and also to tailor to our patients.
That's an excellent point and an excellent view of the future that is going to come ahead of us. So just making clear, the benefit was 0.62, the hazard ratio for the PFS, from the blinded radiology review, the PFS was 29 months. That's a lot for lung cancer, like 2 years and something with just one treatment. That's very impactful. However, the PFS2 and the overall survival does not look that interesting for now. What do you expect in the future once the overall survival and the PFS2 data becomes more mature? What is the hazard ratio that you look to see if this is a valid strategy for patients?
So I don't think I'm going to give you a number because any hazard ratio below 30, we're all happy. But let's break down overall response rate first, right? The overall response rate comes probably from the osimertinib, because we have seen that in Flaura, we saw that in other previous studies when osimertinib was studied in the second line. So the target therapy is able to provide the shrinkage of the disease because we didn't have those overall response rates with chemo, right? So the overall response rates jump when we added the targeted therapy. I think chemotherapy, what produces is probably the benefit and the progression-free survival because it controls the other potential no clones in it, because EGFR is not the same, right? No, all EGFR mutations are the same, and like anybody, EGFR mutations sometimes come with luggage. And I'm gonna circle back to the discussion about patient selection. Not only the ones with positive circulating tumor DNA, but the ones with co-mutations. So I tell my patients, no EGFR is the same. Do you have a T53? Do you have a RB1 de novo, a T798 de novo? So all of those characteristics, I think, are going to help us determine who goes in Flaura 2 and who stays with Flaura, normal Flaura. Progression-free survival, beautiful. But progression-free survival 2 is the one that's going to show if the concurrent versus sequential is beneficial. So I think, when I use the reference of the dating profile, you see the dating profile, that's progression-free survival, and you're like, oh, he looks good, he's handsome. But then you need to wait until you go on the date to see, and that's overall survival, and that's progression-free survival too. Is it concurrent to sequential better? Osimertinib has a place in EGFR. We just need to determine who will get it and what is that. And because we have a progression-free survival of 29 months, it's going to take a while for that overall survival to come to us. But this opens the door. I'm going to call my patient. I have a very young patient, 41 years old, that I just recruited into the study I told you in Memorial Sloan Kettering, and I'm going to call her to share these results because she was very nervous about needing chemo. But now I have data to say, I think based on your T53, high tumor mutation, and your ctDNA, like high allele frequency, I think we should consider the chemo. And now I have data that I didn't have 2 hours ago to try to discuss the benefit, because these patients are in appeal. I had an EGFR patient before I came here that needed some fluids because she did a marathon the weekend before and she was dehydrated. It wasn't the pill. And she's like, yeah, go to the chemo suite. And she has been my patient for 2 years. And she's like,
where is the chemo suite?
Where is the chemo suite?
Yeah.
And I'm going to get chemo. It's like, no, just fluids, but that's how we call it. So it's also an aspect of quality of life, which was measured in the study. But in order to know the quality of life, we need time. But I'm just happy about the results because it gives me a little bit of space for those patients.
Lastly, the most intriguing point that I saw in the presentation is the higher benefit of the CNS disease patients. We all, at least we knew that chemo does not affect CNS disease. That's why we treat patients with radiation before we start chemotherapy.
Yeah.
Theoretically, we don't get response rates, but we see now in the presentation that the benefit is even higher for patients who already started with CNS disease and not for those patients who develop CNS disease later. Why is that? Do you think, is there something about being the blood-brain barrier being broken, and once broken, if you prevent or if you lower the tumor burden, you're going to prevent new disease to go? I think that was very intriguing to me.
I think there's two things. First, who are the patients that present with CNS metastasis? The patients that have more aggressive disease. Potentially patients that have more severe co-mutations and a more high-risk profile, right? We do know that the blood-brain barrier breaks, the higher the frequency of the cancer and the burden. So I think here, the confounding factor is that those patients probably have more aggressive disease, so they benefit from the chemotherapy, right? Because of the nature of the disease. But I think this data eventually is gonna be subgroup divided, and we're gonna see who are those patients with CNS metastasis. We don't know who they are yet, and what is their genomic profile. In addition, pemetrexed, I believe, may have a synergic effect with osimertinib when it comes to CNS coverage. But that was surprising to me too. You know, I wasn't expecting that. And one question for all of us, now that we have Flaura 2, what is the role of radiation at first line, right? I less and less use radiation in my ladies. And I had a young woman, most of my patients are young women, had a lot of disease. And I was like, okay, let's give it a chance to osimertinib, because it was whole brain radiation or me praying to baby Jesus that the osimertinib worked. CT scans in 6 weeks, 30% reduction. I prevented these younger women from getting whole brain radiation. And the problem with whole brain radiation is after you give it, you cannot take it away. And my patients don't do well. So I think for those patients that may have significant CNS disease, the addition of Flaura may allow us to delay or completely eliminate radiation to the CNS. And the patients with EGFR mutations don't have any other comorbidities. We did have 30% former smokers here, and I want to talk about that, but they don't have any other comorbidities. So the CNS progression is going to significantly affect their quality of life and survival. So I was very happy about that.
And we do not know the percent of patients with CNS that got second and third line subsequent therapies, because usually those patients, they do not get to a second line, and then anticipating chemotherapy might be of some benefit.
I'm very excited about the data because I think it's changing and it's giving more options to our patients, and it's making the treatment of lung cancer more complex.
Yep.
Right? It's not only about EGFR, it's like what's the type of EGFR, which commutation, presence of CNS metastases, how is the allele frequency and the liquid biopsies. And for me, it's just so stimulating.
It's interesting because the future, it's very promising, because we're going to have studies like the ones you said, but we're going to have studies combining with VEGF inhibitors now with the ADCs. So EGFR is not going to be the automatic, okay, EGFR, let's give this pill and we're done with it. We're going to have to think about it and select patients, so that's great.
Yeah, I think we need to talk to our statistical friends, because we have to create models. Something that you can get in your phone and put your patient with EGFR, and it will give you a risk profile like we do it in breast cancer. And then you're like, oh, she's high risk, chemo OSI. Oh, she's low risk, OSI alone. Oh, brain, OSI plus BEF. About ADCs, I think ADCs will probably be a second line, third line, because they're quite toxic.
Yeah.
And
especially combining with other
and I never had a patient run a marathon in an ADC or chemo. They have run marathons and OSI, but no in the combination regimens.
All right. Thank you so much, Dr. Florez, for being with us. And I wish you guys enjoyed this discussion, and you can keep following us on the media.
Thank you so much.
Thanks.